Thank you, Dr. Ledley, Dr. O. I'd like to thank the organizers for inviting me. It's always a great honor and pleasure to come to Korea. I want to congratulate Dr. Lee, Dr. Hong, and Dr. Kim on their fantastic new transplant program, the great outcomes. So I'm going to talk about desensitization before and after transplant. Oops. Let's see, how do we advance this? Nope. There we go. I have no disclosures, except I'm going to talk about the off-label use of a number of drugs to try to desensitize patients. So sensitization has become a bigger problem to a large part because we're using more patients are requiring mechanical circulatory support, and that seems to be a trigger to the development of antibodies. So this shows the distribution, the percentage of antibodies. When we talk about sensitization, we're generally talking about antibodies that are against HLA antigens, and those are the targets on the cells of the donor organ. So, and I'll discuss why this is important in a few minutes, but this is a breakdown from the ISHLT registry of the percentage of patients who have high sensitization. So about 2/3 are not sensitized at all, which is good because we can transplant those patients easily. And the highly sensitized patients, greater than 50%, is probably less than about 15% in total. Oops. And how do we determine this? There's a number of ways of doing this. We can get donor lymphocytes. We use fluorescent antibodies, and we have them bind directed to certain antibodies of humans, and we can see whether they're, and then we use we use blood from the recipient. So this indicates these are antibodies that are against this cell, and then these are antibodies that we use to highlight this so that we can document that these antibodies are present. And another way of doing this is to use beads with purified HLA antigens, get serum from the recipient, and again document that there's the presence of these antibodies. And these are different ways of doing this. Part of the reason why we're seeing more sensitization is because we're using more sensitive assays. So we use Luminex, which is highly sensitive. Now, why is this important? Pre-transplant, it's important because it limits the donor pool. If you have somebody who is 80% sensitized, that means that they have antibodies against 80% of available donors, which means you're limited to 20% of the population. That lengthens your waiting time. That lengthens your mortality on the waiting list. That may make you put a ventricular assist device in somebody to support them till transplant. And why is it important after transplant? It's important after transplant because it can increase the risk of rejection, particularly antibody-mediated rejection. It can increase the risk of graft loss. We heard about PGD, and one form of secondary PGD is antibody-mediated rejection, which if you're not careful, if you transplant across, put a heart in somebody who has antibodies against that heart's antigens, you can get antibody-mediated rejection. And there is evidence that sensitization can increase the development of the transplant coronary disease, cardiac allograft vasculopathy. So what causes sensitization? Well, prior blood transfusions, infections which seem to drive the immune system, prior transplants, either prior kidney, heart, any transplant can sensitize the recipient to HLA antigens, prior cardiac surgery with a homograft. Homografts have HLA antigens on them. Gender, females are more likely because many females are multiparous. And when women are pregnant, they're exposed to the HLA antigens of the fetus, about 50% of which are not theirs, they're the father's. African Americans are more likely to be sensitized for reasons that are not clear. And then patients with ventricular assist devices are also more likely to be sensitized. So how do we manage these patients? There are a number of strategies. The virtual crossmatch essentially is a way of getting around the presence of sensitization without actively desensitizing the patient. So it's a passive strategy to exclude potentially harmful donor-recipient matches. Then there's aggressive active desensitization. There's transplanting across donor-specific antibodies, which may not be the best solution, but we've done it in the past. And there are ways to blunt the effects of donor-specific antibodies using plasmapheresis, perioperatively, immunoglobulin, cytolytic induction, and complement blockade. So the virtual cross-match is to identify the presence of donor-specific antibodies in the recipient, determine what HLA antigens they're against, and then just say, we're not going to take an organ with those HLA antigens. And you tell the organ procurement organization, we're not going to take an organ with those HLA antigens, so you get around the fact that they're sensitized, and you don't have to give them potentially toxic drugs to try to bring down antibodies. There's the calculated PRA, which is the percentage of donor hearts in a given population to which a heart transplant candidate has significant HLA antibodies. So somebody who, let's say, has a CPRA of 80% is highly sensitized. They have antibodies against 80% of the population in the region, and it's going to be difficult to get them transplanted. So this is determined by entering the unacceptable antigens into the UNOS. UNOS is the National Organ Procurement Organization or Donation Organization. They have an online system, and you use a CPRA calculator, which uses HLA donor frequencies known in the population to determine the CPRA. And the threshold to determine when an anti-HLA antibody is significant is defined by the individual program. So there's some programs that may be risk takers. The other important thing is not all antibodies are the same. So some antibodies may be very strong, and others may be cytotoxic, which you can determine in vitro. What's called C1q binding, which is binding to a fraction of complement. So antibodies that bind complement are more likely to be destructive to the allograft. The higher the CPRA, the harder it is to find a donor. 70% CPRA means that 70% of donors will automatically be turned away. And so you have a recipient who's on the waiting list for long periods of time, who may be deteriorating hemodynamically, then ultimately get a ventricular assist device. That introduces a new set of risks, a new operation with a risk of infection, stroke, and further sensitization. This is a comparison of prospective versus virtual cross-match. We used to actually do prospective, post-transplant. What we do is we will see if there's actually a true cross-match by getting serum of the recipient and combining it with a lymphocytes from the donor. And so it shows the virtual cross-match is very high positive predictive value, high negative predictive value, so it's very, very useful for us. Now this shows the outcomes on the heart transplant waiting list from the UNOS registry based on the CPRA group. So what you see is the higher CPRAs are less likely to be transplanted than patients with low CPRAs, because these patients have far more donors available. And the waiting time goes up the higher the CPRAs are. You see a higher waiting time here in 80 to 100% CPRA patients than patients who are 0 to 20. And also, post-transplant mortality is increased the higher the CPRAs. So all of this has led to the idea that we need to be not passive and just depend upon the virtual cross-match. We need to be more aggressive in terms of getting rid of antibodies. So that's what we do, why we do desensitization therapy, to improve the chances of obtaining a compatible donor, shortening the waiting time, improving survival on the list, reducing the number of VADs put in. So we try to decrease the CPRA. We reduce donor-specific antibodies to a level that prevents endothelial damage, and we favorably affect the outcome post-transplant. So the threshold that's used in a lot of programs, including ours, in the past has been a CPRA greater than 50%. Above 50%, we would initiate desensitization measures. And there are a number of different ways of doing this. You can take the antibodies out with plasmapheresis, and by giving immunoglobulin, IVIG, Just taking the antibodies out doesn't cure the problem, it's just a short-term fix because the cells that produce this, the B cells, are still there. So you can alter B cell populations by using rituximab, an anti-CD4 drug, and bortezomib, which is a drug that is used in multiple myeloma, but what it does is it prevents excretion of, it inhibits proteasomes, which are involved in excretion of antibodies. IVIG immunomodulates the cells, so it inactivates antibodies. And then if you're in a very difficult situation where you've gone across a positive cross-match and the patient's having antibody-mediated rejection, you can use eculizumab, which blocks complement. This, by the way, is the most expensive drug in the United States. So this shows from Cedars-Sinai the results of PRAs pre and post treatment. So you can see that there are some patients in whom there's no response and some patients in whom there's a significant response. And so there are people who do not respond to the desensitization protocols, and that, so you've given them drugs, but you haven't improved their chance of getting transplanted. This shows the 5-year survival of treated sensitized patients versus untreated sensitized patients. There was no difference. So desensitization does not improve survival. The one thing that's important to know is that you have to avoid putting transplanted organs against which donor-specific antibodies respond to. That's a no-no. That can be catastrophic. One thing that is clear is that treated sensitized patients have greater freedom from any treated rejection, cellular-mediated rejection, antibody-mediated rejection, than untreated sensitized patients, so a consideration. And there are antibodies that are refractory to response. The group at Cedars-Sinai has used bortezomib to treat these patients. That's kind of the big gun. These are people who failed IVIG, plasmapheresis, rituximab, still had CPRAs above 50%. And so they gave them bortezomib. This isn't to be done by the faint of heart. Bortezomib is essentially a chemotherapeutic agent. We were involved in a clinical trial briefly, which was shut down by the NIH because of the risk of bortezomib, but these patients had to get these drugs in the ICU. So they're wonderful drugs for multiple myeloma. They're difficult drugs to use in patients with advanced heart failure. The Cedars group has shown significant reductions in antibodies using bortezomib with plasmapheresis. So it is an effective drug. And this shows a reduction in antibodies using plasmapheresis and bortezomib. In terms of transplant outcomes, again, the only benefit is what you'd expect, which is improved freedom from antibody-mediated rejection. You get rid of the antibodies that cause AMR, you have less AMR. But there's no difference in terms of infection, cellular rejection, or survival. Now, what do donor-specific antibodies do? They damage the endothelium. These are the antibodies. They bind to complement. They attract macrophages, and all of these specifically destroy the endothelium. They activate complement, and monoclonal antibodies and cytokines, and this further damages the endothelium and damages the allograft. So this led to a small single-center clinical trial from Cedars-Sinai again, where they used eculizumab, which is an inhibitor of complement, in highly sensitized patients. And what they found was that they were able to improve cross matches. There's no data to show any improvement in survival. And in the United States, we are very dependent upon getting insurance approval for drugs, and the insurance companies do not like us using eculizumab. It's hundreds of thousands of dollars. And these are the preliminary outcomes from this small trial, which really did not show it wasn't randomized, but it did not show compared to historic controls any significant difference in outcomes. And so this points to one of the things that is increasing or driving sensitization, which is the increase in mechanical circulatory support. You see this here. In the ISHLT registry, which I think you saw earlier, about 50% of patients worldwide are supported with VADs. In the United States, it's about 60%. In our region, the region that Dr. Ledley showed with nice buildings, Independence Hall, and the Art Museum, it's about 80%, so it's very, very high. These are the predicted post-VAD PRAs, and they're more likely to be elevated in females than in males. And in terms of waiting times, patients with higher PRAs, of course, had higher waiting times post-VAD. So think about this. You have a VAD patient, they're sensitized, they have higher PRAs, which means they wait longer with VADs. So they're more likely to have all of the VAD-related complications, infections, strokes, VAD failures, GI bleeding. So what happens with sensitization? Well, in terms of outcome, rejection, sensitization does not seem to affect outcomes. And so there's a thought that maybe the antibodies that are produced by the newest generation of VADs, the continuous flow VADs, are not as pathologic as VADs the antibodies that occur from other modes of sensitization, like prior blood transfusions, organ transfusions, prior pregnancy. And survival of patients with continuous flow VADs stratified by sensitization, there really is no difference between groups. So this raises a question as to whether these patients should be desensitized. And the only important thing to note is that patients, the mortality in sensitized patients who do not reach transplant remains high. So the only reason that I would try to desensitize these patients is to get them transplanted. If they never make it to transplant, they'll have high mortality. This shows C1q, which is a fraction of complement, binds to the antibodies and damages the endothelium, attracts platelets, neutrophils. None of this is good. And this shows that if you have antibodies with C1q binding, patients are more likely to have antibody-mediated rejection, cellular rejection, and cardiac allograft vasculopathy. And the outcomes of patients with C1q binding antibodies are worse post-transplant than those without. So if you identify antibodies that are C1q binding, those are antibodies you might want to target. Again, outcomes are worse with C1q binding. So, in summary, the number of sensitized patients awaiting heart transplants increasing. Sensitization limits the donor pool, increases the waiting time and the waitlist mortality, and is a risk for antibody-mediated rejection, cardiac allograft vasculopathy, and mortality, except perhaps in LVAD patients. Perhaps those antibodies are different. The virtual cross-match has been revolutionary in allowing us to expand donor pool, but antibody-mediated rejection remains an issue. And despite the availability and use of a variety of therapies for desensitization, treatment response is limited. You saw in one of the previous slides I showed, some patients didn't respond at all. And my experience has been you bring the antibodies down, but if you wait long enough, they come right back up. Clinical data for therapy is sparse in terms of survival benefits, and there needs to be clinical trials in desensitization. Now, I want to talk about one thing that was an interesting observation we made many years ago before we had widespread availability of VADs, is we sometimes had to cross antibody barriers, and we used donor-specific cross donor-specific antibodies, and we used a regimen of plasmapheresis, IVIG, rituximab, and cyclophosphamide. We did that in 4 patients. All those 4 patients are still alive, and so we've tried to figure out what happened. And they developed something called anti-idiotype antibodies, which are antibodies that bind the donor-specific antibodies. So we think that somehow we manipulated the immune system. So these are some of the new therapies: C1q esterase inhibitors. Tocilizumab is an IL-6 inhibitor, which is being studied in an NIH protocol to look and see if it can be used to treat antibody-mediated rejection. So anyway, thank you, Gamsahamnida. Thank you for inviting me.